Greetings everyone. I'm from Taiwan. I'm Dr. Su. And today I'm going to talk about advanced clinical endodontics with the 3D image technology. And this is my experience. I got my DDS and I master degree at Taiwan, and I also an endodontics specialist. And I have the experience of using the kind of endo navigation system and all the digital software here. And this is Taiwan. We next to China, next to Japan. And this is my workplace. And we have the TSMC, which is Taiwan Semiconductor Company, and the famous bubble teas. And and when it comes to the before the advanced image technology, I will explain a little bit of traditional and modern endodontics, and we go into the static navigation and dynamic navigation. And later we have the clinical case and my take-home message. And first is the traditional and modern endodontics. Of course, we learn of traditional things, but I think maybe we are not doing this anymore because we still use high speed and maybe GG drill, but we shift a lot into the canal shaper of rotary a lot, and maybe you use hand. This traditionally use hand file, but we use the modern endodontic. We use rotary now. Of course, we got microscope, ultrasonic for the remove of the pericervical dentine and to do more minimum invasively. And we have the CBCT, of course. So modern endodontic, we do the minimum invasive, but I'm not to talk about the truss or ninja access today. But we can see a process that we open a lot at the traditional, but we kind of go to more conservative nowadays. But how conservative it is not the topic today. We also can use the all kind of this access, including like if there is a restoration, we can do restoration oriented access or the caries oriented access. If the ultra conservative or the truss is more controversial, and this is anterior tooth, of course. And so if we shift from the traditional one to the conservative, we can conserve more pericervical dentine. But of course, if we open more small, we make it smaller, the cleaning and shaping will be a little bit affected. But this is not the topic today. So I'm talking about the traditional and the modern, and now we go into the digital technology, what we can do. Like if you find a tooth and it got classification here, you cannot find it in microscope. Or you have these tools like this, the distal root and with the post that might not be very easy to remove. And if you want to do the surgical, of course we can consider the replantation. But if we got a very thick buccal bone here, we reflect the flap, we cannot find it. What can we do? So we go into the static and navigation, dynamic navigation technology. So we can see a lot of the digital restoration now. Of course, we have the reality tools of patient, and we use the scanner, oral scanner, to put all this information into digital world. And we do the digital design and use CAD/CAM or 3D printer to manufacture the restoration back to reality. So it's the same concept that we use this in endodontic. With reality, we got skull bone and tooth, root canal, and we take CBCT and oral scan. We get it into the digital world, and we design the digital access in software, and we put it back in reality using a navigation system or 3D print guide. It's the same concept of the digital planning of implant planning. So let's see, this is published in the Journal of Dentistry. This is the tools after CBCT scan. You can see the calcification here and the apical part of the apical pop. And so they design a surgical guide and do the guided endodontics. And this is my publish also, and just running it very fast. And of course, you can design a non-surgical and surgical guide in any kind of ways. This is non-surgical guide, and surgical guide you got maybe this kind of that can keep the flap out of your surgical field, or these two kind of you can drill direct into this tube and find your apex. All of kind of this design. So this is the workflow of the digital design. We take CBCT oral scan and put it inside the software together and design a 3D print guide. And we 3D print it, it come out with the static guide. And of course, this is the surgical part, surgical kind. And when it goes into the dynamic navigation, the design process is all the same with the static guide. It's just dynamic. And in the dynamic navigation, we have the tracker here that appear very likely to the QR code things here. And when you're using this navigation things, you use the guide tracker here, and the monitor, the video capture here will tell you where are you now. So you design you buy this tracker and take CBCT, and this tracker attached with the QR code will mix this information inside the computer and tell you where you are now. And this is just like the satellite. This two camera here is like the satellite, and the QR code here is maybe your phone, your iPhone, your GPS here. And the distance of these two and the distance between this, they will calculate it and give you the feedback into the dynamic navigation that you're doing. So if you heard about all this, because we not have a lot of time and you don't have the concept of this, we see the clinical case. And with clinical case, I got non-surgical with static guide, and surgical with static guide, and non-surgical, surgical with dynamic, 4 cases. So let's see the static non-surgical first. This one with apical lesion and maybe hypersegmentosis. At the apical side, we put a tracing here, got into the distal root canal. And after we remove the crown and do the endodontic retreatment, we found out the mesiolingual canal was obliteration. So we take a CBCT, we do the digital design, and here the yellow line is the surgical plate, is the guide plate, and the green point here is the drill pass that I designed to drill past the calcification into the mesiolingual root, the mesiolingual canal. And here is the picture here. This mesiolingual canal, and this is the drill pass that I designed in software that I will use to enter the canal. And this is the guide plate in software, and this is another section you can see. And so this is the 3D reconstruction of these tools. You can see the irregular part of the root, and the green cylinder here is the path that I designed. So I printed out, and I manufacture a metal sleeve here and use the Mons discovered burr, and the shank will fit into this hole, and I process it, I drill in it. But everyone seeing that, they will ask me that, did you drill direct into the space? No, I put it 1 to 2 millimeter at a time, and I remove the plate and I check with path file, irrigation, and do anything, maybe microscope, and put it back and do it again, 1 to 2 millimeter every time. So this is the microscope picture that after I use the guide plate, the mesiolingual root. And this after I find the root canal, I remove all the GP and to check the main cone and do the root canal filling. And as you can see, there's more radial opacity path that I drilling with the guide. This is the finished root canal treatment, and this is the 2-year follow-up. The apical lesion is almost healed, but not complete healed, I think. And next we go into the static guide with surgical. And this patient with the apical lesion here, and we because the pulse is not seem to be very easy, it seemed to be maybe easy to remove, so we do the endodontic retreatment first. We finish the endodontic retreatment, which it got the 2 canal here. But after we finish the endodontic treatment, but patient still feels swollen there, so we decide to do the surgical. And we put the CBCT and oral scan together and match it into our tooth, into a model. And we designed with the model that we got the tooth here, and this cylinder here is we trying to get to the apical part of this tooth. And this is the 3D print guide. And this is the video, but I don't think I have. I'm over time already. Okay, if you don't want to, you want to stop, please let me know. And this flap reflection. And this case, I specially designed the guide will attach on the bone directly rather than soft tissue. It have no gap between the print guide and the bone surface. And I remove with the tree fiber. So this is the reason why I designed a surgical guide, because there's intact buccal bone that you after flap reflection you might need to find it. You might find that you drill around and try to find the apex. And if you use the surgical guide, it's more easy. And I use the tree fiber to remove the apex simultaneously. But this is not necessarily you use the guide plate to remove the apical part. It's not necessarily. You can use the old way to cut it. That's all fine. And I placed a little collagen material and put the bone plate back and suture it. And this is the apical. You can see you got isthmus here. I think that's the reason that why retreatment is not good. It's not effective. So after the MTA filling and suture, and this is a tooth part fragment. I cut it. You can see the isthmus inside. And this is after surgery and 3 months follow up. And 2-year follow-up. Still a little bit radiolucent here, but I didn't put a lot. I didn't put bone graft, but I think it's okay. It's okay. So next one is the dynamics non-surgical endodontic. This one is a patient complained about very long-term soreness of this tooth. And luckily, this patient go to the perial department, follow the perial condition. So I got from the 2014 to 2012, 2022, the X-ray. And at the 2022, you can see the big amalgam filling as a little bit fracture. So you can see the pop space is continuously, gradually not visible as the time goes. So the patient still, after discussion, the patient still feel soreness and he want to solve this problem. So he come to the endo department. So after I open the tooth, I cannot find root canal at all at the microscope. So this yellow part is that I put after I drain pop and I feel I cannot find it, and I think I'm going to perforate it here. So I put a little bit Vitapex for the radial opacity here, and took a CBCT. So the red part is the pop, and this yellow part is where I drill. And as you can see, I'm almost entered a little bit close to the bifurcation. I almost perforated. So after so that I cannot find, so I designed these two drill paths to actually enter in the root canal. So this one, the design is all like the static guide, and this one I use the X guide for the drilling, and this is dynamic. So here is the two cameras see my image here, and the green line or the blue things is the QR code flag, the QR code. Yeah, so you can see if I drill the green the yellow circle here, it reach the green bar here. That means I reach the point I got. Yeah, I enter. Yeah, and then you can see the dynamic here. So after I reach the root canal, I do the root canal treatment, irrigation, enlargement, and finish. So this is a 6 months follow up. And patients are good. The soreness is gone. And last one is dynamic navigation with surgical. This one is also a very long post that we are afraid to remove. So we decided to do the apical surgery with this cylinder here. We designed to cut the root tip, and you can see the mesial one and the distal one, mesial one and the distal one. Yes. And this is actually we are doing the navigation here. So you can see my eyes is on the screen. And check this and try to drain into the apex. So I usually tell patient to buy the tracker because that makes the tracker more stable. And this is after I cut the root tip. And of course, the isthmus is prepared and filled with MTA. And this is the bone plate that I got into it and I put it back. And this is the post-operative. And this is a 3 months follow-up and 1 month, a 6 month follow-up and 1 year follow-up. And the apical lesion is gone. And if you are interested in all of this, I have my e-poster at the square, I think. So you can put my name in and check it. And into my conclusion, I'm not gonna to read this. If you like, you can take a picture, or you can find it on my YouTube channel. 3 seconds. 1, 2, 3. Okay. I can get back. I can get back. And the conclusion is the static and dynamic navigation is apply the CBCT information direct into your execution directly, rather than you see the CBCT and think, where is it? Where is it? Yeah, directly you can get the information, but it requires certain learning curve. It's not very easy. It's not very easy, and the treatment concept doesn't change at all in modern dental, endodontic, or surgery. The concept is all the same. It's just a tool, and the static navigation and the dynamic navigation that get you where you cannot see directly in the microscope. You cannot see it. Maybe you can imagine it, but you cannot direct see it. And it tells you the way. That's what means the navigation means. And thank you. You can scan the QR code to my YouTube channel and maybe email me. All of the contact is okay. Thank you.